Solution for presbyopia and refractive error. I have with me my colleague Dr. Rakesh Shah, and we'll be taking you through multiple speakers who are expert in their subjects and doing some innovative work. So we start with Dr. D. Ramamurthy and his experience with IPCL. Dr. Ramamurthy, please. Check. Okay. May I request all the speakers to come on the dais and join us? Kamal, you would want to join us? Suvira, can you join us, please? I would request all the speakers to stick to time because we may not have any long time for us.
Chairperson's friends, the outset I'd like to thank Hoya for putting together this symposium. Can I? The topic given to me is IPCL, my experience. Relevant to this particular presentation is that I am a speaker for both STAR and AIOC. Actually, my experience with phakic intraocular lens started with VeriSize between 2002 to 2006. Then almost for 6 to 7 years I was using ICLs exclusively, and later on I've been using the IPCL also. Today I use both these lenses almost in equal measure and equally happy with both of them, and I'll be sharing you my experience with IPCL. So many of you are aware of the ICL, and they have also come up with a new upgraded version called the ICL Evo, and what we have in IPCL is the version 1, and now we have the version 2. To compare the features of the two of these lenses, as far as the dioptric range is concerned, ICL is never customized. It's from +10 to -18 spectacle power, and here IPCL plus 15 to -30 you have almost off the shelf. And of course some extremes of power might take a little longer to get. Astigmatism is up to 6 diopter correction is what is possible in ICL. With IPCL is almost up to 8 diopters you can get. The material is Collamer, which has a long history of stability in the sulcus, and in IPCL it's a modified hydrophilic acrylic. Initially I had some reservations about this, whether it's the ideal material for putting the sulcus with the natural lens in place. But this lens already is being implanted in thousands of eyes, not just in India but elsewhere. In my own experience itself, this doesn't seem to have had any deleterious effect. But this is something we need to look out for, and then maybe over the years we'll gain greater confidence with this. As far as the number of holes are concerned, we have one central hole of 360 microns in the ICL and 2 paracentral holes. And with the IPCL, it's a 400 micron hole, and the configuration of the hole is such that it's a little broader outside, and it narrows down as you go in. And apart from that, there are couple of holes here just at the edge of the optics, and these para-optic holes are there. And all the 4 haptics, it actually has 6 haptics, all these edges have fairly large openings. It is said to allow free circulation of fluid from the back of the lens to the anteriorly. This also lessens the mass of the lens, because of which even if there are minor inadequacies in the sizing of the lens tries to settle down and does not cause excessive vaulting, and I think that is a great idea. But of course this makes it a little difficult. Initially when this lens was brought in, it was only the leading left haptic and the trailing right haptic which had holes, so it was easy to identify. Now they have a small protrusion here and a small dent over here, but when you are aiming at keeping these two on the upper end, then usually you get the lens opening up the right way. But maybe having a better marking than what they are presently having would be a good idea. And now since both these lenses are coming with a central hole, a peripheral iodotomy is not really required. And this lens has 6 haptics compared to the 4 in the ICL, and maybe giving better stability to this lens. And The ICL, especially the toric version, they do only have it at certain powers, and since it's imported, it takes some time to come, and all these lenses have to dialed into place. Of course, they have a chart accompanying which tells you whether it's 11 degrees, 15 degrees, sometimes even 17 degrees. But the good thing about the IPCL is each and every toric lens is customized so that it's at exactly 180 degrees is what you need to place, and that makes it easier. I already mentioned about the size of the holes, and the hole in all 4 haptics, and it's dispensed in BSS as far as ICL, it is dispensed in saline, so there's a little propensity for the lens to enlarge after implanting. The loading is quite different as far as the ICL is concerned. You have to get comfortable with that. While with the IPCL, it's very similar to plate haptic IOL. So in case you have used some of the plate haptic intraocular lenses, adapting to these lenses would be quite easy. As far as the size itself is concerned, I think there's a great advantage as far as the IPCL is concerned. For a long time, ICL used to come only in 4.9 to 5.8. Now, for some of the smaller powers with the EVO version, they come up to 6.1 millimeter. We must remember that the optic zone size that we get on the cornea is about 1.25 times. So, when you have a 6 millimeter optic, it almost corresponds to a 7.5 millimeter optic zone size for a laser vision correction. On the other hand, with the IPCL, you have, even for a long time, we have had a 6.2 millimeters available. And in case you are coming across large scotopic pupils, the custom-made lenses have even these larger optic size without increasing the overall size of the lenses available. So I think that's a great advantage. And when you have large scotopic pupils of, say, 6-7 millimeters, getting a customized lens so that dysphotopsia from the edges of the lens is avoided is a good idea. Just to show you a short clipping of loading of these lenses and implantation, you can see it's a good idea to use just normal saline. Initially it was a little bit of methyl cellulose and normal saline. Now I use only normal saline. Actually my sisters are quite adept at loading it and giving it to me. And you just place the lens in the ledge and keep it in one of them and then introduce it into the other. Then you have to push the lens to the edge of the cartridge and press down on the lens while closing it, and that ensures that none of the lens gets stuck. And then it's just like you have a injector, and it's very similar to what you use with the intraocular lenses, and that's the paracaine being injected. It's that 90-180 that we make the incision. I usually make a 3 to 3.1 millimeter incision because I do not want a wound assisted implantation, and that gives me better control as far as low implantation of these lenses is concerned. And it's only for the last 3 or 4 months that the lens with the central hole has become available. This is a slightly older video, so you won't see a central hole in that, but in all other respects the lens is quite similar. And this is a toric markings on the lens. There's a fairly large optics of the lens. And you can see these 2 holes has to be always on the upper side, and it's always injected into the anterior chamber, then gently nudged into place over here, and you can see the lens being positioned behind the pupil. Just in case the pupil is widely dilated, then it's a good idea to burp out a little bit of viscoelastic so that the pupil comes down, and that helps you to position the lenses properly. Nowadays I use high molecular weight viscoelastic like Helon, and after placing the lens in position, when I inflate the incision, then the entire viscoelastic just gets burped out. Otherwise you have to remove all the viscoelastic completely. I think I'm going to skip these couple of slides because I think the subsequent speakers will be dealing with that. But I essentially want to share our experience of about 3 years using the IPCL, and it's a retrospective analysis. The period of study is from August 2014 to May 2017. We started using these lenses then. The total number of toric IPCL is about 134 and spherical IPCL about 35. 80% of the lenses that we use are in toric, and I think that's important because even though the patient ends up spending a little extra money, it's important that you tend to correct any cylinder beyond 0.5 diopters, because otherwise they are unhappy with the residual cylinder. And the hyperopic eyes, though a wide range is available, only 2 eyes have been hyperopic eyes. And I thought most of the patients we do are bilateral, but I was quite surprised to see that there's a slight predominance of right eyes, and that of course has no clinical significance. And as far as 60% nearly females and about 40% male patients. And the indications, as I said, 150 myopia, just 2 eyes of hyperopia, and most importantly, keratoconus, once it is stable, whether because of collagen cross-linkage or because of the age of the patient, 21 of these patients in this particular analysis were patients with keratoconus, post-classic in 4 eyes and post-keratoplasty in 1 eye. And as far as the age distribution, as expected, 80% of the eyes belong to the 18 to 27 age group, and even the extremes of age, some of them even at the age of 35, 40, we have done a couple of eyes. Range of sphere up to about minus 21 diopters, and you can see up to 6 diopters of cylinder also have been corrected, and this lens can be customized up to about 23.25 is what we have used, but even a higher range of power can be custom made. As far as the results were extremely satisfactory, we had analysis for all 134 eyes for 6 weeks, for 113 eyes for 6 months, and what we found was the mean sphere was just 0.127. And the stability was also extremely good, that over a period of further follow-up, there was no significant change in the residual error, and that the same thing applied to cylinder. So the kind of correction, of course, the mean spherical equivalent and outliers would be there, was very satisfactory, and you see that the lenses have been functioning quite well. And as far as change in lines, the preoperative best corrected visual acuity to postoperative uncorrected visual acuity, which tells you the efficiency of these lenses. 110 of these eyes maintain the visual acuity, while about 43 eyes did show an improvement, and this is expected when you're especially correcting higher grades of myopia. Many of these eyes belong to the keratoconus group. I'll briefly dwell on that. And as far as preoperative best corrected to postoperative best corrected visual acuity is concerned, which is important from the safety angle. Majority of these eyes maintained good visual acuity. It was only 4 of these eyes which lost 2 lines, and all these eyes belong to the keratoconus group. And basically, and as far as safety is concerned, at 6 months again, the results were quite good. And repositioning was required in 8 of these eyes. And mind you, my tolerance for repositioning is quite low. Even if the patient has minus 0.5 with a plus 0.1 diopter of cylinder, I go ahead and reposition these lenses. And especially since there are a significant number of keratoconus cases where determination of the exact refractive error itself is a challenge, some of these eyes did require repositioning. That was about 6%. I would say that it's important that we reposition these lenses to get optimal outcomes, and especially if the spherical equivalent of the residual error is almost 0, these patients seem to do quite well. And we had to explant 1 eye because of high intraocular pressure, and otherwise these are some of the minor complications that we faced in the postoperative day 1. All of them could be managed with medical treatment. Again, complications at 6 weeks, IOL rotation in 8 eyes, raised intraocular pressure which could be medically controlled, and cataract, small paracentral opacities, none of them were impairing vision. Very quickly, I know my time is up. Keratoconus 21 eyes, and many of them had significant cylinder, and you can see that the correction even in these group of patients was extremely gratifying. Of course, in these patients you do not promise refractive accuracy, but debulking is what you promise. Essentially, as far as these patients are subjected either to a topo-guided PRK or an intact segments so as to make the cone quite central, and then subsequently these toric ICLs are implanted, and significant number of them experienced a gain in vision. So basically, the thought I want to leave you behind is that implantation of IPCL is a safe and effective procedure for good refractive correction for myopia, hyperopia, and astigmatism, and in stabilized centered keratoconus patients also. I think it's good to have the freedom of choice, and phakic IOLs have come to stay as a significant armamentarium in a modern day refractive surgeon. And this is a very cost effective solution which is readily available to us. I think we would do well to adapt this. Thank you so much for your kind attention.
Thank you, sir, for that wonderful lecture and about a comprehensive of your usage of IPCL. We will keep the question at the end, but because Dr. Ramamurthy would be leaving, if there are any questions for Dr. Ramamurthy, he surely can take it. So if not, I would ask you one more question, that what are the chances of cataract? People were worried about this lens, the biocompatibility of the lens, and what are the chances of cataract? Do you see a lot of cataracts in your cases?
See, as such, it is reasonably established, even with a 150 micron of vault, the chance of cataract is extremely low. Previously, we used to go by 250s to 750, 150 microns of vault. And of course, my concern was because of, this is of course studies based upon what we have seen in the ICL. My concern was whether because of the change in material, whether the significant incidence of cataract will be higher. But as you could see, we have a 3-year follow-up. 2 of these eyes only developed paracentral opacities, which are also not progressing, and we have not explanted any of these lenses. And I do not know whether any other studies specifically on these lenses available about incidence of cataract. But especially with the central hole also coming in freer circulation, I think that's not a major concern. Now, as the time goes by, I'm adapting these lenses more and more because I find that they function equally as well as ICL. And I think whatever data we have for ICL, which has been around for a longer time, is applicable to these lenses also.
I think that's a wonderful point. Anything new, we would be initially a little bit jittery about that it may not be very biocompatible. We keep on waiting for 1 year, 2 year, 3 year, 5 year. We have been using these lenses now more than 6 years also. So we can safely say that for 6 years it's not going to have cataract, and we know the cataract is not going to come overnight. So having such kind of reservation in our heart is normal. But rest assured, there are more than 75,000 lenses implanted across the world, more than 1,000 surgeons. So it's not very new lens. Well, it's just a question of time, somebody writing a big series about it. But overall experience of every surgeon is, we are fine in terms of biocompatibility. Yes, sir, you have one.
One question to Dr. Ramamurthy. To the beginners of using ICL, how do you...
IPCL.
Yeah, IPCL, that's what I meant.
Right.
How do you recommend to take the pre-operative measurements in form of Y2Y and other parameters?
Okay.
A large number of machines which anyone different parameters are available.
Actually,
so what are your recommendations?
Actually, I think Kapoor is covering that, but should I just basically that the calipers measurement is a good idea of taking the measurements, and we make the patient lie down, put a speculum, and under the operating microscope we take this measurement. Making them sit down and on the table, doing it in the OP is not a great idea. And we always compare it with an op scan or a topolizer. And the basic idea is that these things should correspond. Sometimes if you're just taking with an op scan, if there's a vessel or a pigment at the limbus, you might get a slightly larger measurement. And once these two things are aligned to each other, we are quite happy. The only thing is laser interference biometry like an IOL master might give you a slightly higher measurement. I think Kamal will dwell upon this more.
Thank you, sir. Thank you, Dr. Ramamurthy. I think it's a wonderful opportunity to share my experience and why I would call an IPCL as a complete refractive solution. Let's see, what do we call a complete refractive solution? Why would I use the word or a sentence as complete refractive solution? There are various options of availability in phakic lenses, but would all of them qualify for this term as complete refractive solution? That is the point I'll be putting across. There are lenses from biotech, there are lenses by ICL Star. Even yesterday in all the debates, when people talk about phakic lens, I don't know why they only talk about ICL. There's so many of them. There's so many phakic lenses. But I think it's become a point of reference, but it's just a matter of time. People will change. They will evolve. I myself was stuck up in time 4.5, 5 years ago, but I've transformed my complete practice to the IPCL. Done nearly 1,200 IPCLs. I think Sanjay would probably know, probably the highest study in the country. 1,200 IPCLs done, long follow-up, 4.5 years. Only 6 explantations, Rotations, again, when we went back to the drawing board, there were issues with our white-to-white measurement. One patient had a different S2S and a white-to-white, which we compared on a UBM. So there's out of a series of 1,200 patients, one patient actually goofed up because of no fault of the surgeon. It was just nature's fault that the S2S and the white-to-white were not matching. There was a 0.75 millimeter difference between S2S and white-to-white. So each time I would dial the IPCL, it would rotate. It would rotate vertically. I did it twice, then I contacted Sanjay and he said, UBM karke dekhte hain, sir. So I did a UBM and there was, definitely it was wider inside. So now there are various combinations available. I will not get into them, but you have Biotech, Vision lens and RIL by Appasamy. Now what are the refractive issues? Keratoconus, high refractive errors till -30. I've corrected till -32, which again I think is probably a record. I don't think anybody has reported that. Highest astigmatism corrected, 8 diopters, corneal scars, post-traumatic. Astigmatism high, refractive presbyopic IPCLs. I've started doing that. Putting presbyopic phakic lenses in pseudophakic patients who've been operated earlier by you, where you've done a cataract, now the patient wants a multifocal lens, or the patient has a residual refractive error. In fact, just yesterday before I caught my flight, I did a surgery for a lady who come from Chandigarh. She had a Symphony lens put into her and she was -2.5 residual refraction post-Symphony. And she came to Delhi. So people were saying, do a LASIK, do a PRK. And I said, I don't want to touch a cornea, especially in a lens which has got a continuous focal optical zone. I don't want to mess around with the cornea. I just went in, I put in a phakic lens. The lady was 6 by 6 within half an hour. Half an hour after I took the patch off, she was 6 by 6. So it addresses all issues. So that's why I would say if the ACD is matching up to you, this is the product to actually latch on to. I would not get into this. IPCL sub 2.8 millimeters. You have a +15 to -30. You can correct up to +8 diopters. Another beautiful thing is the variability option available. Most of the other products in the market are stuck up. They will give you either 0.5 increments in size and they would stop at a particular optical size. And again, I guess, again, the K goes to, I put the largest IPCL I put is 8.5 millimeter optic size. And it works. I put it in a girl who was -29 with 4 diopter cylinder. And she's doing fantastic. Not get into the design, but there are some basic good advantages with this lens is it's got 3 prongs on each side. I use a special enclavation technique over time I've evolved. I go in for the center one first. I put the center one behind the RS. Once that's done, it frees up more space on the opposite side, and then I go and do the other one, and then I put the other 2 in. I'll show you some videos for that. I usually use a viscoelastic. I don't use a methyl cellulose. My style of putting in the lens is reverse to what Dr. Ramamurthy showed. Over time, I've evolved a style. I would rather fold the lens backwards like a book, unlike the way Dr. Ramamurthy did, because I've realized with that method, a lot of times, if there's a leak of viscoelastic, as the lens opens, it touches the crystalline lens. So it's a good idea for the lens to open like this rather than like this. When it opens like this, it touches the crystalline capsule. So over time, I've evolved that. So who are the patients who are ideal for that? Patients high myopes who have, residual thickness is less. They don't want to go for LASIK for some technical reasons. You don't want to go for LASIK. Irregular corneas, dry eye, surface disorders, corneal scars, and whatnot. These patients want freedom from glasses. So what we've done is +6 diopters with 29 diopters. We've done 8.5 diopters. We'll see videos. The best part is the toric lenses do not require any rotation. I think that is a genius Newtonian idea. Most of the times when you do a toric lens, you are bound down by 2 things. First, measurement of your keratometry. Second, marking of your principal axis. And third, rotation to that relevant axis. Now, suppose you have a lens which has got a built-in astigmatic correction at the required axis. All you need to do is push the lens in at 0-180 and the thing is done. So some issues, I've done some explantations. I had one explantation, the one boy who got into a fight, he got punched in the eye, he developed a cataract. If we have time, I'll show you how I did that surgery. I did the complete cataract surgery without removing the IPCL. The IPCL was on top, I did the rexis underneath, I did complete phaco underneath, and then I put in the lens. The reason being, if suppose I wanted to explant the IPCL, this was a big optic IPCL, I might need to extend the wound to 3.2 millimeters. In a high myope, there would be a lot of chamber fluctuations. I might need to close this wound, make another wound. So I decided to just do the whole surgery under the IPCL. So the lens was so delicate and so soft that it allowed me to do the whole surgery under the lens. Extreme power sizes, 11.5 to 14 millimeters. I don't think such a beautiful range of 0.25 millimeter increments is given in any other product. Optic size can be, customized to any power you want. It goes up to beyond minus 30 also. And as I said, the master punchline is toric lens needs no rotation. Wide to wide measurements, I'll just show you. I hope these videos work. Yeah, they work. Okay, now I'm showing it on a series. What do I do? If I'm using an automated method, I go on a manual edit mode. So I'm showing a video here. I'm manually, in this particular case, there was pigmentation at the limbus. The machine gave me a bigger white to white. So all my teams are trained to correct edit. So all readings, now you see this is an accurate white to white. So once this is done and I do an OK on that, the white to white changes. So the moment I do that, see what happens there. It says 13.8, it's become 12.57. So it's a good idea to counter check if you're using an automated method. Now another idea is always do a pupillometry. Most of us, when we do a phakic lens, we do not do a pupillometry. Do a mesopic size pupil size and do a scotopic. In case you have a high-end machine which has got a pupillometer, do that. In case you don't, I'll tell you another method of doing that. I hope this video works. Yeah. Now we switch off all the lights when we do a scotopic, and the machine will tell me all the variable sizes. Now we're doing a mesopic, then photopic, and then dynamic. You get an average. So I take an average and I take a scotopic. I go 0.75 millimeter, at least bigger than the largest pupil size. That is the reason when people with other products say that, ICL, some patients have a glare. And probably the poor hole also gets blamed for that. But I think it's a lot to do with they've not done a dynamic pupillometry. So that's one reason we have more happy patients with this particular product. Now this is the end result. This is not clear. Again, see, I have the smallest pupil is 3.43. The largest is 6.75. Now I plan the size of my lens. Normally, most of the products will be available at 6.2. Now suppose I put a 6.2 optic diameter lens in this patient was going to shoot me. At night, he would have glares, edge glares, photopsias, and then he would be very unhappy. Now another method I do is to measure the pupil. If you don't have a high-end machine, switch off the lights in your room, use an autokeratometer. Most of the new autorefractive keratometers have pupillometry measuring devices. See how we use them. I hope this video works. Yeah, it's working. So, the room is absolutely dark. There. Now I'm going on the measure mode. I'm moving the bars to the largest pupil size. I took a still image of the largest pupil and then moving the other bar on the other side, and you'll see the bar moves 7.2, 7.1, 6.1, 5.9 and 4.8. So this patient is 4.8. In case you don't have a high-end measuring pupillometer, you can use a simple autorefractive keratometer to do that. And the best part is you can use the same to do your white to white. So we, as a standard, do a cirrus oblique a pentacam. Then we use an axis keratometer followed by a digital vernier caliper. In my hands, I don't think the digital caliper is so accurate. Now I'm doing the same thing here. I'm measuring the white to white. There, the bar moves back, and nearly there, it's 11.3, 11.4, and I've gone back a little bit further, come back again. It's around 11.6, 11.5, 11.6. So this is what you do. And in the end, there's a complete sheet with all the details, axial length, anterior chamber depth, different measurements, and this is what goes. You can mark the cornea on a slit lamp for your 080 reference marking. I'll skip the video. Now we'll just go for this. This is minus 16 with minus 2 diopter cylinder. This is the girl with minus 29 and I think minus 29 with 2 diopter cylinder. And this is preoperative and this is postoperative. This is immediately after surgery, half an hour. You can actually see the glow. This eye is dilated still. You can see the glow in this eye. This is 2 hours after surgery. Minus 27 with 3 diopters, postoperative. This is twins. This brother got operated both eyes. This guy was a little afraid, so he was waiting for this guy. to get operated. They're both twins. Then this guy came in. Now this is again, I want to show 8.5 diopters of optic size diameter. This is an 8.5 diopter optic size diameter. I would challenge any other company to manufacture that for you. Of course, the nomograms are different. Again, two brother sisters operated on the same eye, -12 and -10 with cylinders. Again, -18. I've got so much of happy, success stories. Now we'll just go for some. I will skip the normal videos. Advantage of having a toric pre-marked lens is you don't need to dial it. Just position it to 0-180. That's what you need to do. You just mark your 0-180, place the lens on 0-180, and you're over. You don't need to dial it. So that's one. Again, I think I'll just see this video. We'll just jump. I'll go fast. Yeah, look at the size of the lens. Look at the size of the pupil. The white to white in this patient was 14.2. So you can imagine the size of the lens. And the lens goes and sits in beautifully. And one or two videos are interesting. Prelex. We've started using it for presbyopia also. Again, this is interesting. The patient already has a pseudo-phakios and he's got a residual refraction. You correct the refraction along with correction of his presbyopic correction. Now this is the surgery just done 2-3 days ago. Multifocal lens, patient has got -2.5. All you do is you push in the lens, pick up the lens. So I was in a session before, somebody was talking about explantation of IOL in case of an IOL error, IOL refractive error. I said, that's been ages. I've never explanted the lens for a long time. And that's what you do. You push in this lens. It's a very thin lens. Once it's inside the iris, there. The surgery is over in 4 minutes. No need to do a LASIK. No need to explant the lens. Just push in a lens which is approximately 80 to 100 microns. And since this is a pseudo-phakic eye, the anterior chamber is so deep, you don't need to worry. Don't need to do even a PI. So I guess PI enlargement, surgical PIs, we can skip that. Should I skip this video? Okay. Thank you.
Here is Dr. Suvira Jain. She'll be giving insight about the trifocal IOL. We have a lot of trifocal IOL available in the market now. Dr. Suvira will give more about the true trifocal, that is from AIOC.
Right. Hello, good afternoon. How does this move? Yeah. So Benjamin Franklin in 1784 was so excited when he discovered the bifocal glasses. It makes us realize that not only from centuries ago, but even more so now, addressing presbyopia is all but an inevitable need. The demographics of longevity are changing. People are living a lot more and different kinds of lives. And you can see that it's estimated that by 2020 in US, you'd have 20% of the population who are over the age of 65 and 50% of them having an operable significant cataract. And if we were to look at the new gen elderly, they're very different from the older elderly that we had. They perceive themselves as being younger, both in age and outlook. They do perceive themselves being a lot younger. They're confident. They're in control of their lives. They no longer want to hoard possessions, but they want to live a life of experience and adventure. Okay? Coupled with that is, there is no doubt that this is the era of smartphones and tabs, and they're ubiquitous and present everywhere. If you put both of these together, you find that research has shown that even as people approach 65 and beyond, more than 60% of them are friendly with the internet, and more than 70 to 75% of them go online every day. And that's what makes you wonder that what then is the most perfect IOL? I would think, therefore, we would tend to steer towards offering multifocality as an option for these patients. So the perfect, even if you were to look at a multifocal IOL, the most perfect lens would be one which allows the most natural way of seeing, providing as completely as possible a restoration of all visual function whilst minimizing the side effects. So presbyopia correcting IOLs that came into the market have revolutionized the way we look at cataract surgery today, because evolution of materials and designs allow us for balancing out of your functionality and reducing the side effects. And this is the range of all the IOLs that have come into the market over the last decade or more. The issue that comes with the bifocal IOLs, we know it gives you 2 point foci, one distance and one near. But the biggest drawback there is a significant lacuna in the perception of mid-range vision. Accommodating IOLs work while changing the dioptric power of the eye by changing their position, either by moving forward in the optic, but that requires the pliability of the lens capsule and again can be rather unpredictable. The edge-slit design of the extended depth of focus IOLs, true, they do give you some amount of a significant range of intermediate vision, but there is almost always a compromise in the near vision, as I have seen and most of us have seen as well. So that gets us to thinking that which is the lens that's probably the one that's going to give you the perfect balance between distance, intermediate, and near vision, and minimizing any of the problems. And the trifocal IOLs seem to be the answer to that. And the tri-diff trifocal of IOCare seems to deliver what it says it'll promise. The way in which these trifocal IOLs are created, you've got two bifocal lenses which are superimposed one on top of the other, giving you three different foci. So now, not only do you have a focus for distance, you have a focus for near, which works like a 3.5 ad, and you have an intermediate focus. So you have the third point of focus, which works like a 1.8 ad. So this has got ridges, as you can see. Now what you need to know is the height of the ridge determines the amount of light that enters for near. The width of the ridge determines what is the near ad. So wider the width wider the width of the ridges, less is the near ad. Nearer they are, greater is the ad. So that's how it really works. Another subtle difference in its design is that there's a rounding off of the edges of the peak as well as of the trough. All of this results in reduction of the overall glare and the other photic phenomena. Dynamic energy transfer is another thing you need to understand. It's simple. It is actually streamlining the distribution of light depending on the ambient lighting conditions, and that's how the apodization on this lens surface really works. In apodization, you have the ridges, these ridges that go lower and lower as you move from the center to the periphery. So how does that work? Under normal lighting conditions, when the pupil is small, you have more amount of light that goes in for near, and as the pupil dilates in mesopic conditions, or when the pupil dilates, more amount of light, because the ridges are going down in size, more light is allowed for distance. So even the light near distribution is extremely well balanced out. Also, the spherical abrasions in this length correction is almost to zero, and you have almost minimalization in the reduction of the overall contrast sensitivity. So I will just, I'll come on to, where is my, so this is a small video of the lens. So it comes in both designs. We use the plate haptic one. In terms of the biometry, it works very well. The A constant works as 118.28. This is the lens, as you can see. You have to orient it such that the leading haptic has a hole on the top left and the bottom right. And it's a nice thin lens that fits very easily and is injected equally easy. I should just show that to you. So that is just the lens. And under HPMC, with significant ease, it is loaded in place, flexed in, and once the injector once the cartridge is shut, it is injected with ease into the eye. It's brought out onto the surface, and extreme ease, it goes into the eye and sits in the capsular bag. Again, then, we obviously need to know that the surgery has to be pristine and well done. Look for the centration and the orientation of the first and third Purkinje images. They should be well aligned and in sync with the center. And at the end, it would appear like this. So I'd like to just share with you the results of a small study that we did where we looked at the lenses in great detail. So the way in which we actually had to you want to evaluate the visual performance of any lens, there are three things you need to look at. One is the visual acuity, where we looked at the uncorrected and the corrected distance, intermediate, and near visual acuity. Second is we looked at the contrast sensitivity, and finally we evaluated the range of vision by doing the defocus curves. The biometer, I would suggest that when we do use these premium lenses, you stick to any one biometer that works for you so that you can end up optimizing your A constant if required. We used an optical biometry, and we took To start with, we used two formulae, which is the SRKT and the Barrett, and we went with the closest to the minus, and we took the A constant as 118.28, which is what is suggested by the company. The visual acuity, which was checked in all our patients, and using this biometry, this is what we found. In our total 15 eyes that we got, we found that 25% of our patients ended up with a planar refraction, and about 53% had a tiny cylinder of about 0.5. So 80% of our patients were almost near normal, and only three out of those 15, that is 20%, had a small spherical residue of about not more than minus 0.5. And finally, then that's the one part of it. But then when you need to actually understand, is this lens or any lens actually performing in terms of giving you that intermediate range of vision, we did that using the defocus curve. Now, what you need to understand in the defocus curve is it works on it is the objective way of evaluating the range of vision for intermediate, near, and distance. And the way you do it is by just evaluating the visual acuity at different distances. It works on the refractive principle that f is equal to 1 by d, which means where f is the focal length and d is the diopters of accommodation. So to see clearly at 1 meter, you need to use 1 diopter of accommodation. Similarly, if you were to plot a defocus curve for a pseudophakic eye, so for a patient to see clearly at 1 meter, the lens should have inherent in it 1 diopter of accommodation, and that's how it can be worked out. So to see clearly at 66 centimeters, accordingly, you need to, the lens should have inherent a 1.5 add. And it's plotted like this, wherein the horizontal axis shows you, and how you do it is keeping the distance correction in place. You keep adding minus lenses, so that's on the horizontal axis, and the vertical shows you the vision. Now, in a monofocal IOL, this is the kind of pattern you'll get, where you get a little bit of pseudo accommodation and a drop. In a bifocal IOL, you'll get that typical double hump, which you do get, but you have nothing working in your area for intermediate vision. And these are our graphs of our patients where we looked at when we did the trifocal IOLs. These were the graphs we got. So for example, if I were to look at graph number 13, if you see at 1.5, at 66 centimeters, the patient still has 6/9 vision. So we evaluated at at 66 centimeters, the kind of vision we got. And this is what we found, that 33% of our patients had a visual acuity of 6/9 or better. If we took 6/12 as a cutoff, which is standardized, considered as normal for even drivers, for driving in the world, we found that almost 75% of patients had fabulous vision in the intermediate range. And finally, we looked at the contrast sensitivity. What is important in looking at the contrast sensitivity is the Snellen acuity works on the principle of having a fixed contrast of 94%, which does not replicate what we have in our day-to-day living in normal different lighting conditions. So we use the Mars contrast sensitivity chart after stabilizing and standardizing the background illumination to 265. This is what, and then we needed to compare it with something. So the near normal, people in their 40s and 50s had a contrast of about 1.7 to 1.8. And this is what we found, that 66% of our patients had a log contrast sensitivity of more than 1.6. And if we took it between 1.5 and 1.59, about another 25% fit in that range. And it was even better than the commercially available other IOLs. The study for this is farther on. And finally, I've come to realize that at the end of the day, you want a patient who is happy. Whatever else you get are just numbers. And we found that patient satisfaction related to the fact of what he perceived his visual acuity to be, whether all his needs were met or not, whether he was having any photopic phenomena, and what was his vision in night, in dim lighting conditions. And subjective perception at the end of the day still depends on his personality, his need for extreme close work, and what is his environmental illumination. And finally, so in our study, we found only 2 patients who were not so happy. None of them, because in the evening time they needed brighter light, which I find with all class of multifocal IOLs, they have to understand that they are going to need much brighter light for near work. None of the patients had any photic phenomena. And finally, you have to understand that if the lens doesn't work for you, or if the patient is unhappy, you have to rule out other causes of dissatisfaction, which is, it could be even a spherical ametropia. A small cylinder can cause cause significant amount of glare and halos. Any residual astigmatism or a spherical residue? Does the patient have something like a dysfunctional tear syndrome, because that again causes abrasions and halos, whether he's got a Yagerbil posterior capsule or a cystoid macular edema. In conclusion, I would like to say that if you've been absolutely sure about your biometry, if you've ruled out any other causes of ocular comorbidity, if you've understood that which of the visual needs of the patient you need to address, if your surgery has been precise, then I can assure you that the TriDiff trifocal would deliver, and how. Thank you very much. And this is an interview of the patient, but nothing more than that.
Thank you, Dr. Suvira. We'll take a question in the last. What we are going to have new is a new treatment for the macular disease. IMAX IOL, can you just show the video?
OLAMD's IMAX Mono is a groundbreaking intraocular device for improving vision in patients with macular disease. Age-related macular degeneration, known as AMD, causes visual distortions and the loss of central vision, making it difficult to drive, see faces, or read. Vision loss is normally gradual, occurring over many years, and peripheral vision is not affected. AMD is the leading cause of visual impairment in the developed world, and it is estimated that many tens of millions of patients could benefit from a specialized lens solution to help with their AMD symptoms and improve their quality of life. Unfortunately, many sufferers still believe that nothing can be done. In a world first, the team behind the award-winning IOL AMD technology now offer an advanced AMD treatment that incorporates the benefits of IOL AMD and IMAX into a single lens. IOL AMD's IMAX Mono is the world's most advanced intraocular lens for AMD. It's injected into the eye via a tiny sutureless incision. If IMAX Mono is implanted during cataract removal surgery, the lens will be placed in the capsular bag, similar to most modern intraocular lenses. When IMAX Mono is implanted in a patient who has previously undergone cataract surgery, the patient's existing intraocular lens will remain in the capsular bag, and a different version of the IMAX Mono lens will be placed in the sulcus, just behind the iris. IMAX Mono lenses feature unique and advanced optical characteristics which could improve the vision and lives of tens of millions of patients. Once IMAX Mono is in place, it cannot be seen from outside the eye. Standard monofocal lenses produce sharp images in the center of vision, where the macula is located, but are not as sharp in the periphery. When a patient has macular damage, they will often compensate by shifting their focus to a healthier section of the retina, and the standard monofocal lenses leave these patients with blurry vision where it is needed the most. A greater improvement is now possible with IMAX Mono. The effect of the IMAX Mono procedure is to gently magnify the incoming image and provide a higher level of clarity across all areas of the surrounding retina. This can provide significantly improved sight for patients who are not using the macula for central vision. When implanted in both eyes, the brain can utilize images from the healthiest parts of each eye in combination. This can reduce the negative effects of damage in one eye by filling in the visual gaps from healthier areas of retina in the fellow eye, creating a composite image that maximizes the patient's potential visual ability. If the macular disease gets worse over time, the patient can shift their focus to the area of healthiest retina, giving some protection from future disease progression. The entire surgical procedure takes around 10 minutes per eye and can be performed under local anesthetic. In addition to AMD, the IMAX Mono lens may be beneficial for patients with other forms of macular disease, including diabetic maculopathy, macular holes, myopic degeneration, and hereditary retinal diseases such as Stargardt's and Best's. Depending on the visual potential remaining in the eye, an IMAX Mono patient could regain the ability to drive, read, or see faces, significantly improving their quality of life. A trained IOL AMD eye doctor will be able to explain prior to surgery what visual improvement could be achieved. If you are interested in learning more about the IOL AMD IMAX Mono procedure, please visit our website at www.iolamd.com.
So for AMD, we had a previously telescopic IOL which had very large incision, very bigger size and lot of complication. Then it came under mini telescopic IOL. Then we had a Hubble IOL, which was a combination of two different powers in the eye. But now what we have is a IMAX, which is a hydrophobic acrylic material, which is a special hyper wavefront design, and it gives an eccentric, that is a 10-degree eccentric from the macula, and it magnifies your image. So magnification is almost 1.2x. The case selection is very important for the initial few cases. So you need to select your cases which are macular scar, either because of dry AMD or a regress stage of wet AMD, somewhere vision between 660 to 612. That is the ideal case. Again, you need to have a binocular rather than selecting only one eye initially, which one eye magnify image and other eye normal image, patient will get a diplopia. So you need to have very binocular patient which can easily go. Don't select very scarred macula in the beginning, and it just goes with your standard 2.8mm incision. It's a hydrophobic acrylic material. So now it's available in India, and definitely initial case selection is very important. All these patients, you can always try with the first low vision aids, that is a telescopic normal monocular telescope. If patients are really improving, you can suggest this patient, and especially for binocular cases. We don't have Dr. Pavla who was supposed to give this talk, but his insights are there. Can you run the other video? Yeah. Please start.
Good afternoon, everyone. Thank you, Fritz. Thank you, Bobby, for getting me part of this exciting group. Now, what I will do this afternoon with you is share my clinical experience with this lens. I'm lucky enough to be part of this group since the beginning, so I have like 1.5 years experience with this product. Now, as you've heard, this IOL is specifically designed for patients that have macular disease, and the way this lens works is basically giving a good quality picture up to 10 degrees away from the central macula. Now, as Professor Hartal has clearly explained it before, a standard lens gives you a good picture in the center, but a bad picture is in the periphery, and that's good for a standard patients. Now, AMD patients, they do not use most likely their central part of the macula, they're using their peripheral macula, and they're not getting that good of a picture over there. So one way to improve their vision is with these optics, and the other way to improve their vision is by magnifying the images, and that's obtained aiming at post-op refraction on the hyperopic side. And I will go into details on how we choose our post-op refraction on each patient. Now, as it was clearly explained by the other speakers, this is how a standard lens is working. It's giving you a sharp image in the center, but not as sharp in the periphery. But if you have AMD, then you're not using your central part for vision. You're using a peripheral part of your macula, and then you're using an optical system which is not optimized to give you a good image there. What happens with this lens is that you're gently magnifying the image, and you're also giving them a good quality picture up to 10 degrees of peripheral macula. And that's what's actually making the game work. So I will be sharing with you my...
So good part about this lens, you can put it in a normal phakic patient who are already having a dry RMD or with scarring as a first implant, or if your already patient is pseudo-phakic, you can get a customized implant made as an add-on lens, that is an IMAX add-on, so that is also possible. So initial good case selection is very important, and now it's available with the care group with us. Any questions on this and for trifocal? Any question? So we'll close the session. Thank you. Yeah.